بينت عندك البرزنتيشن؟
We are live.
Yeah.
Good evening, everyone. It's a pleasure for us to have you once again in our webinars. Today, I would like to welcome a friend of mine, Dr. Ahmad alamarnah. We did some lectures together in Dubai and everywhere. I think Ahmad alamarnah, he's holding an MSc in master in aesthetic from Italy. Yes, Ahmad, no?
Yes, from Italy, Marconi University.
Yeah, we have been together in Marconi University.
Yeah.
It is a nice place, Viraj.
Very nice. Yeah.
And nice Italian food. Huh? So I will. You are going to talk to us about posterior restoration.
I'm going to talk about the posterior composite restoration, the secret of posterior composite restoration, about restorations free of sensitivity, free of failure, maybe something like this, inshallah.
Okay, can't wait. The stage is yours. I will share your screen.
Okay.
Stage is yours.
Inshallah. Bismillah. Good afternoon, everybody. I'm Dr. Ahmad alamarnah from Palestine, Jenin. I don't know if I can speak in Arabic or in English only, so I will try to speak both languages because I don't know the audience nationality. So first of all, we are going to speak about the secret of posterior composite restorations. There are a lot of secrets, but if you follow it like every steps that we are going to talk about, you're going to have a restoration that will last at least for 5 to 10 years if the patient follow all your guidelines, okay? So let's talk about the presentation. Let's start. First of all, what's your goal when you are doing a restoration? Is it to be a famous, to publish it on Facebook, Instagram, Snapchat, to get more likes, or something else? You can divide the goals in the devil way or in the angel way. For the money and the fame and workflow, you can do a lot of restorations without following any rules. You can do the stamp technique. We call it stamp technique because we're using our finger to put the restoration in its place. And the patient will go and see a white restoration, and he is satisfied with the restoration, but after 1 month, 2 months, 1 year, it will fail. So the other goals we have is the reputation, longevity, function, and aesthetic. You are concerned about your reputation. You are going to do your work more than 10 years. So you have to build a reputation that will last forever until you die. So we are combining both goals to have the ultimate restoration, the ultimate workflow in our clinic, okay? What's the obstacles about the composite restoration? Composite restoration is a technique sensitive. So the composite, it's a modern type of restoration. In the old time, they were using amalgam restorations, and it's very good restoration. A gold restoration, the ultimate restoration. But the seeking for aesthetic led to the invention of composite restoration, which is have the same color of the tooth. So the seek for aesthetic led to invention of the composite restoration, but there's some drawbacks for the composite restorations. It's a technique sensitive. It can be affected by moisture, even from the breath of the mouth. So when the patient breathing, the water vapor in the air from the patient mouth can affect my restoration. So there will be an obstacle. It's a technique sensitive. Second thing is the sensitivity after the restoration. The patient go out after doing the restoration. After 1 week, he suffers from pain during mastication, or after 4 months also pain, dropping pain, pain on cold, pain on hot. So it's very, very technique sensitive also. The last thing, the last problem, the last obstacle that we are going to concern about is the aesthetic appearance, the anatomy, the morphology, the surface, okay? So let's talk about the technique sensitivity. Because it's technique sensitive, we must use rubber dam. Because rubber dam protect the field that we are working with, and also give the patient, give the dentist the time he needs, and give the patient the comfortability, let's say, and protect him from the let's say amalgam debris when we remove amalgam. Let's see the first picture here. It's a very good isolation. I do isolate the 7, the 6, and the 5. Look at the involvement here, or let's say the enveloping of the rubber dam around the sulcus of the tooth. Dr. Mohab?
Yes.
I don't know if everything is okay. I'm
Everything
speaking.
is okay. If a problem, I will come. Everything is okay.
Everything. If anything is bad or something, send me a message on Messenger, okay?
Yeah.
Can I speak with Arabic or only English?
I think English, because you have non-speaking Arabic audience here also.
Can I mix between them?
If you use some Arabic words, you have to retranslate in English, because we have non-talking.
Okay, let's continue. Okay, I do isolate both the 6, 7, and the 5. Always when you do use the rubber dam, isolate a tooth before and a tooth after, because we need to have a wide field for working, and also you don't know if we have a defect in the 6, okay, and it will turn to be a class 2. Okay, so you have to establish or re-establish a contact. So if you do isolate only the 6, you will not be able to re-establish the contact between the 5 and the 7. So always isolate tooth before and the tooth after. And in this picture, I will speak about it later. I do use the floss. If you see it, the floss on the 6, I will point it here. Yeah, it will aid and help you to envelope the rubber dam inside the sulcus and expose more of the tooth structure. But when I do use the rubber dam, I always have some problems when I first introduced to rubber dam and use it. This problem, I think everyone who used rubber dam have it. The tear of the rubber dam, and also the hurt of the interdental papilla, the injury of the interdental papilla. So those problems have their solutions. Let's see the solutions. First of all, when you start your treatment, always, all the time, if you have multiple teeth, or if you have a class 2 and you're sure that you have class 2, pre-wedge before you initiate your preparation. Some of the lecturers, they say, I do preparation before I do use the rubber dam, and I use the rubber dam for the restoration. No, because you don't know if you have pulp exposure or nanopulp exposure, and you will have then a bacterial infection and later on failure of the restoration. Okay, so always have the rubber dam. At this picture, I will show you this is not a must to use the shield. Okay, this brand, I mean this brand, but this shield, the idea of the shield can be done by using a normal wedge, a wooden wedge, with the normal matrix sheet or matrix metal. Okay, you can put the matrix metal, a separated one, you can cut it with the scissor and insert it between the two teeth. Okay, and insert the wooden wedge, the normal wooden wedge, to protect the adjacent tooth, because most of the time when we do the class 2 restorations, when we are preparing it, the pair scratch the surface of the normal tooth, the healthy tooth, near the infected one, and thus will make like a rough surface. The rough surface will have more bacterial accumulation, later on caries, because of the surface energy and the increase of the surface energy and reactivity, blah, blah, blah. Okay, so always protect the adjacent tooth. Always, always. Okay, next. Flossing, as we said before, flossing will expose more of the tooth structure that you need to see, okay, and also seal from the clavicular fluids, okay. At this picture, like the previous picture, look at the exposure, more exposure. Look at the cement-to-enamel juncture here, okay. This picture is a beautiful one for the anterior teeth. This side, the right side of the patient, left side of the picture, okay, with the floss inserted in the cervical area, okay, and here without any flossing. Look at the difference here. Look here. It shows the caries and the healthy margins. So you can establish your restoration at the healthy enamel all the time, okay, or dentine. And also we can use Teflon and Liquidam. What's Teflon? It's the normal tape that we use for the pipes in our homes. And the Liquidam, it's any liquid composite that comes with the, maybe with the whitening kit. Maybe you have a cheap, I don't know if you see me or not, but this is a cheap liquid or flowable composite. I use it for isolation also, and creating some ideas inside the patient mouth. Okay, for this patient, I do use only the W8 rubber dam clamp and isolate it only. I don't know why, because it's the 7, maybe, okay, and it's class 1. Okay, I have some leakage here, so I use the flowable composite, okay, the Liquidam. And the second picture, I use the Liquidam as a custom wedge. I use it to, I use my instrument to compress the ring here, the matrix system here, which is, I think, Opti Matrix, I think, okay, from Care, Pro Matrix. Something, I don't know what's the name, because I spent the last 2 months in my home. Okay, so I put the liquid rubber, okay, the liquid flowable composite and cure it to create a custom curvature here for this tooth. Okay, and I also can use the Teflon here. Those samples, you can use it in different ways. Okay, you can use it instead of the dental floss also. Okay, this is for the technique sensitivity. Okay, now we are getting ready for our restoration. We do our preparation. So we remove the caries. In the past, they said extension for prevention. They do some extensions, some dovetails, some cavity design in order for the physical retention of the restoration, mainly the gold or the amalgam restoration. But now we are prevention of extension. We have the said prevention of extension. So we only use, we only remove that defected dentine, the dentine and enamel also, the caries lesion mainly. Okay, so we don't have to remove any other tooth structure, because we have the bonding system and we have the composite that will reinforce the tooth structure. Okay, so what we are using to know that we are removing only the caries. First of all, you have to have at least 3 of these ways to complete your treatment. First one, which all we have, is the eyes. Okay, so you have your eyes. You see the lesion. You see the brownish stain of the caries, the active caries. You see the plaque. You see everything. Okay. Second of all is the is the periapical X-ray or bitewing X-ray, or the normal panoramic X-ray that will have the most accurate one is the bitewing, okay? But you can diagnose it with the panorama or with the periapical X-ray, okay? And the third one that I use in my clinic is the caries indicator. The caries indicator here is like the weapon that I use to kill the caries. Why? After I do remove all the caries from the cavity, I see a white clean cavity, and I previously in the past I did I do the restorations, I do everything, and I see why ليش احنا okay, sorry because I'm fasting and I feel so dizzy, okay, and excuse me for my English because I didn't practice a lot, okay, Dr. Mohab.
Yeah, we are hearing you.
Hello,
we are hearing
anybody
you.
Okay, let's continue إن شاء الله يكون كل شيء تمام. Okay,
you can use
so
some
the caries indicator.
But please translate the Arabic then what you said, translate it please.
دكتور انا المشكله انا بحاول احكي كمان كل شويه تاني عشان ما بعرفش اذا انا على اللايف ولا لا.
No, you are live, we are hearing you. If you want, you can check, you can open your phone and you can go to Igora.
انا مش شايف اي كومنتس لانه انا مش شايف اي كومنتس، انا كان بشوف السلايدز تبعوني.
I know we are seeing everything okay. Go on.
خلاص تمام. Okay, so let's continue. Okay, when I start my practice in my clinic, I do use only the two ways, the first way and the second way, my eyes and the X-rays. And I finish the cavity with a wide cavity, clean cavity. I do my restoration, and after 1-2 years, I shocked with the recurrent caries. Okay, so how to be sure that you remove most of the caries? I introduced myself to the caries indicator, and I use it like for 4 or 5 years till now. Okay, and after I use it, no recurrent caries, alhamdulillah. Okay, 99%, let's say. Okay, how to use the caries indicator? Can anybody tell me how to use the caries indicator, Dr. Al-Muhab?
If they can say, they might put on the comment. Let us see.
Can you read some comments, maybe?
Yeah, can read comments. Yeah.
I don't like to only to speak. I like to interact with the comments and something like that. Okay.
Questions and they answer. They will answer if they have the answers. They will answer you on the comments.
Okay. How to use the caries indicator? What's the steps for using the caries indicator? Use the caries indicator immediately after you finish cleaning the cavity and wash it and see if there's any stain or what?
So, anybody have an idea about the use of caries indicator? It seems you have to continue.
No answer?
They will answer because there is a delay of time, but you have to continue and they will answer.
Okay, so when I use the caries indicator, first of all, I have to know that there is a smear layer in the dentin surface or in any surface of the tooth, okay, after you finish preparing your tooth, okay? So if you do the caries indicator immediately, it will stain because of the bacterial byproducts and let's say the dirt in the cavity, okay? So it will stain and you will remove more of the tooth. Yeah.
Maybe with microbrush.
No, this is the application. We don't say anything about the application, but do we use it immediately after the preparation of the tooth, or we have to do something else to the cavity then use it?
You must clean the cavity. Another answer. You must clean the cavity first.
Okay, clean it with what? I did clean it with the pair, with the high speed and low speed. I finish everything. I finish my design.
But with what you are going to clean it more?
Any answer?
You finish it with the by NaCl, NaOCl for a few minutes.
Me, 100%. The sodium hypochlorite. I soak the cavity with sodium hypochlorite to remove any bacterial byproducts and eliminate the false.
You are having a bad connection. We are not hearing you.
They are not hearing me.
Yeah, now it's better.
Shall I repeat?
You have to cut all the Wi-Fi connection that you have around. Just keep your phone only.
You know, we are in Palestine. We don't have the super.
So another.
Do you hear me now?
Yeah, we hear you. Yeah, another was talking about etching. You make etching for it before using the before using the
okay. It's like a diagnosis, not like a procedure for the etching. It's a diagnosis tool. You like we use in the laboratory, like methylene blue, something like this, rhodamine B. Those stains that we use to indicate the bacterial presence in the cavity.
Okay, so the answer is using hypochlorite.
Yeah, I do use the sodium hypochlorite and soak the cavity for like 10 seconds, 20 seconds, and rub it to do like I do some activation for it. Then I clean it with the water and air, triple syringe. Okay. After I remove everything, I put my caries indicator, wait for 5 to 10 seconds, or to the I read the recommendation from the factory recommendation. Okay, every caries indicator have its way to use it. Water, and I see if there is a dark stain, it's a caries. A very light stain, you can leave it. A very light, very light stain. But when you have a more dark stain, it's a caries, and you have to remove it.
We have a question here. What about
and also we have the visual. What?
What about the chlorhexidine instead of sodium?
You can use chlorhexidine. But we are using chlorhexidine at the next steps. So the sodium hypochlorite is more efficient at this stage, okay? Because it removes all the smear layer, or not the smear, all the byproducts, bacterial byproducts within the smear layer. So it's a very good.
Okay, great. Continue.
Okay.
You can continue. If there are any questions, I will interfere.
Hello.
Yeah, we are hearing you.
Hello.
Hello.
دكتور المحب.
Yeah, I'm hearing you.
Okay. The visual inspection, you can have a light, a source of light, and you can use the light cure. There is a setting on the light cure to emit light, okay, and see if there is any cavity, hidden cavity, mainly at the anterior or the posterior, anywhere you want, okay. And there is an electronic caries monitor that it's used like it's like a camera that have some readings within the tooth. And look at the picture here. They have a different colors. Each color represents something, okay? And there's a different company produce different machines like this, and everyone have its reading colors, okay? It's very expensive, no need. Okay? After that, when you do your preparation, you have to be aware about the wall thickness. What we mean about the wall thickness? Let's see this picture. At the first picture here, we have an MOD restoration. It's an amalgam restoration. The patients came to me and he wants to remove it and replace it with the more aesthetic one. after I see this, after I saw this type of restoration, first of all, I did an impression with the, I think it's Zeta Plus, okay? And I did a cut mold technique. If you want to know about it, it's like taking a stamp for the buccal and for the lingual cusp in order to replicate the same anatomy and the same height of the cusp, because after you remove it, if it's removed, if you remove the buccal or the lingual cusp because of the caries or because of the lack of thickness, if it's less than 2 millimeter, you have a cavity that's very huge and you don't know what to do, and you don't have the matrix system that makes you make you I don't know what to say, that replicate the same curvature, the same height, the same anatomy of the buccal or the lingual. Okay, so I did this for like as a precaution. Okay. Then after I removed the amalgam restoration, I did measure the buccal and the cusp, and it was like 3 millimeter. It's more than enough. Okay. Let's return here. Okay. So you have to measure the buccal and the lingual cusp or the remaining cusp. It doesn't matter it's buccal or lingual, mesial or distal. You have to measure it. Okay. If it's less than 2 millimeter, you have to remove it. Why? Or you have to reduce it until you have 2 millimeter. Why? Because after the shrinkage of the composite, the stress that build up within the composite will cause a fracture. You can see the fracture within the cervical area where it's less than 2 millimeter until it's 2 millimeter. Let's say it's tapering, it's 2 millimeter, then 1.5 millimeter, then 1 millimeter. At one of these height, it will break, and you will have a horizontal line because of the breakage. Okay, we have here a picture that shows this is a picture. It doesn't relate to the but I'd like to show it to you. At the first 3 pictures, here and here and here, we don't have to use a fiber post, because every time they asked about when would you use a fiber post, what's the criteria for fiber post, can we use or do a normal restoration or have to do a crown. For me, the only way that I can do crown is the last 2, okay? Because if you have 3, okay, you can do it only with the restoration, normal restoration. This may have to use a fiber post. You can use fiber post here, fiber post here, fiber post. But those 3 don't have. You must not do a crown. Why? Because if you do a crown here, let's say you have a 2 millimeter thickness here, 2 millimeter thickness here, okay, and you did your buildup with the fiber post, okay. So then you have to prepare your tooth, okay. Dr. Mohab?
Yes, I'm hearing you.
Okay.
Yeah, everything is okay. Continue.
Then you have to prepare your tooth after you build it. Okay. So you remove like 1.5 millimeter, 1 millimeter from the thickness of this wall, and also at the same from this wall. You will end with the only restoration hanging out from the root, okay, and you put your crown above it. So it's very weak. Why not you use the remaining tooth structure, the 2 millimeter of solid enamel? This is solid enamel. Use your solid enamel, and it will last more than of the crown. At this one, I don't also use a crown. I use something called taping top. Okay, if it's 2 millimeter, I keep it here, and I do some beveling here, and I do a tabletop with composite or with ceramics. Okay.
Can I ask a question, please?
Further.
The third case that you showed, MOD.
This one?
Yeah, this one. can we make, for example, an inlay only by CAD/CAM? Is it
Yes, you can.
better than composite restoration or what?
Yeah, it's better because it's a controlled material. You did it outside the patient mouth. You don't have the shrinkage, the stress buildup within the composite. Okay, so it's better. But for the patients, the money is matter. Okay, so they seek for a little cheaper, let's say, treatment. So
Okay.
they want it immediately at the same session. So the composite, yeah.
I have other question. If we want to use for this case a CAD/CAM, is it better to use something with composite or with ceramic?
I think with the ceramics,
Okay.
yeah, it's better for the like let's say the longevity of the restoration. Okay,
Okay. Thank you.
next. Okay, should we use liner or any pulp capping material? This question I've been asked all the time. Okay, I do prefer to bond as much tooth structure as possible to the composite because if I do bond as much as I can, I have the more and much more strength from the bonding to the tooth structure. Okay, so the bond is the best liner that it can be, but sometimes the cavity is very deep. Okay, so because of the cavity is very deep, sometimes we don't have a perforation, we have a micro perforation. Okay, so what's the micro perforation and what's the perforation? The perforation is the perforation that you can see. It's 1 millimeter, less than 1 millimeter, and there's blood. A micro perforation, when you see the shadow of the bulb and it's like red, but there's no bleeding, and this is a micro perforation. If you use your bond above it, it may sometimes cause some sensitivity because there's a communication between the fluids within the dentinal tubules and the bulb, and it's very, very close to the bulb. So there will be some irritation. Okay, so all the time they say use a dical, the calcium hydroxide. We say no, we don't use calcium hydroxide. Why we don't use the calcium hydroxide? Because the bonding of the calcium hydroxide, the dical, to the tooth structure, to the dentin is zero. So when you do your dical and it's good, okay, it's in its place, and you do your composite restoration, the composite restoration itself will shrink a little bit. This shrinkage will pull the dical away from the area that you place it and create some space. This space will cause differential pressure and cause some pain and during mastication, and later on it will go to necrosis. Okay, so I don't say all the time, but most of the time. Okay, so what we should use? We have two options, the calcium lining material and the glass ionomer lining material. Okay, I do use the calcium lining material all the time. Why? There's a glass ionomer and there's the calcium. Why we use the calcium containing material, not the glass ionomer? Please let me hear your answers.
What is your question?
Which one we prefer to use, the glass ionomer liner or the calcium lining material, like Biodentine or Therical?
Okay. But now everybody is talking about Biodentine, which is, it seems to be to give good results, no?
Yeah, because it contains also anti-A in the Biodentine.
Okay. I don't know if it is a material here.
Why we use the Biodentine or Therical? I mean by the calcium lining material, not the brand like Biodentine or Therical. I don't know. I don't want to say anything about the brand, but why we use this section, not the glass ionomer lining material? Why we do prefer?
Okay.
Because of the
No, I'm not an expert in this field, so I can't tell you.
Okay, so we are saying about the pH. The pH of the glass ionomer is less than 3. Okay, so we know that that 3 is more acidic than 4, more acidic than 5, with a logarithmic increase. Okay, like here the acidity is 1 multiplied by 10 to the power 4. Here to the power 3. Here to let's say no 4 to the power 10. Okay, it's a logarithm. I don't know anything about the mathematics, okay, but it's like more acidic than the 4, than the 5, than the 6. What does that mean? Answers.
It goes well with composite.
Not the composite, about the bacteria.
Okay.
Okay, more alkaline, more bacteria resistance. Less alkaline, more acidic, less bacteria resistance, and more bulb irritation. Okay? Dr. Mohib, everything is good?
Yeah. I have another answer. MTI or biodontin.
What?
Highly irritation to the pulp.
Yeah, highly irritation to the bulb because it's acidic. 100%. So we use the biodentin and Therical, not the glass ionomer lining material. But I do prefer the Therical over the biodentin because biodentin is very and you have to use the whole capsule one time. And the patient came to you at the first session, you place the biodentin, then as a whole restoration, okay? Then after 48 hours, he will return to you, or she will return to you, and you remove like 2-3 millimeters, 4 millimeters from the restoration, and place on top of it the composite after the setting is 100%. But the Therical, you can use it whenever you need it, and you can continue your restoration at the same time. Okay? And you have control for the quantity that you use. You can use a drop, you can use the whole syringe, you can use anything you want. Okay? Let's talk about the procedure. The procedures here, we have the acid etch, we have responding, we have polymerization, and we have the filling. Okay? Let's say something about the acid etching. Acid etching, simple words, use the acid etch, the phosphoric acid, from 32 to 40% phosphoric acid to etch the tooth structure. But the tooth structure, the tooth itself, consists of 2 parts that we are going to restore it, the enamel and the dentine. Okay, so the enamel is the hard, the tough material, 96% hydroxyapatite crystals. Okay, so it's more tough, it's hard, it's like minerals. Okay, the dentine is 70% hydroxyapatite and 20% collagen, 20% organic material. Okay, so the enamel is inorganic, the dentine is organic. So when you do the acid etching, you have to deal with it as a separate materials, as separate tooth structures. The enamel is something, and the dentine is something else. Okay. At this stage, the timing is the most important thing. Okay, as we said, it's different material, it's different type of tooth structure, the enamel, the dentine. So timing is very important. For the enamel, you can etch it for 15 to 30 seconds, but for the dentine, only 15 seconds and less. Okay, if you do your etching more than 15 seconds to the dentine, what would happen? There's this picture shows the dentine, a cross section of the dentine. This is the smear layer, and this is the smear plug. The smear layer, you can remove it, you can modify it, and you can keep it. but we'd like to modify it in order to have something called a hybrid layer, the hybrid zone. Okay, after application of the acid etching, okay, this is the acid etch. The smear layer will be removed, and the smear lug will retain in its place if you do it like for 15 seconds. But if you lift it for more than 15 seconds, you will remove the smear plug. What would happen if you remove the smear plug? There is a direct communication between the fluids within the dentinal tubules fluids, and your restoration. And because of the mastication forces, the restoration will move a little bit in microns, okay? This will create a different pressures, osmotic pressure on the dentinal tubules and the fluids within it, and trigger a pain impulse within the pulp of the tooth, and the patient will have a masticatory problem, okay? It will have a mastication pain immediately after the finishing of restoration. So when the patient came to you after 2-3 days, 1 week, and he said, I have pain on mastication, be sure that you remove the smear layer and the smear plug, and you have etched more than 15 seconds for the dentin, okay? Another thing, the dentinal tubules fluid will leak in the bonding layer that we will have it later on, and cause something called nano leakage. We all know about the micro leakage. There is a different term called nano leakage. The micro leakage happen on the enamel or on the margins of the restoration, the outer margin of our restoration. But the nano leakage caused by what? Caused by the leakage of the fluids from the bulb, from the dentinal tubules, after you remove everything, the smear plug, okay, and will cause a degradation of the hybrid zone, of the hybrid layer, okay? This degradation and will cause a nano leakage and pain within 1 week after the restoration, okay? The nano leakage and the micro leakage. You have to know the difference between the nano leakage and the micro leakage. Next. So we have a total etch technique and selective etch technique. Total etch technique is to etch the entire tooth at the same time, enamel and dentin. You can do it like this. You can do it like 15 seconds for both of the enamel and dentin and then rinse it, or you can use the selective etch for the enamel only for 15 seconds, then apply the etchant gel on the dentin for another 15 seconds. So the enamel will have 30 seconds, okay, and the dentin will have 15 seconds. So after that you rinse it, okay. So this is the total etch technique. This is total etch technique, 15 seconds for both. And the other one is the selective etch technique that we are going to talk about. The selective etch technique, it's to etch only the enamel. You can use this technique only if you use the correct bonding system. If you use the total etch technique, you can use any system of bonding or any bonding system, okay? But if you use the selective etch technique, you have to modify the dentin. How to modify the dentin? By using a bonding system that have etch in it, a weak etch that's going to modify the dentin smear layer, okay? This is the selective etching. Look, I only etch the enamel. Another picture. This is only the enamel. Different brands of acid etching, different consistency. Okay, different colors. Okay. After you do your acid etching, you have to remove it. You have to rinse it. How to remove it and dry it, okay? You can do it like this. With the power suction, with the bond brush, clean bond brush without any fluids or liquids on it, okay? A cotton palette or a foam palette. I use in my clinic this all four, okay, but I prefer the cotton, the foam palette, and the bond brush, the micro brush, okay. Question: how long you should rinse your acid etching, Dr. Muhammad?
What we have been told long time ago and during our study that we have to rinse for 1 minute. I don't know if it's
100%.
If it's accuracy.
Let's say there is an equation for it. You have to rinse twice the time you etched. So if you etch like 15 seconds, you have to rinse it for 30 seconds. If you etch for 30 seconds for the enamel, you have to rinse it for 1 minute. Why? Because the older dentists that have used the acid etch or the composite from its beginning, they have the acid etching in its liquid form, okay? Nowadays, we have the acid etching in its gel form, okay? So they introduced the gel form because of the debate about only or dentine only. So we have to control the etching gel, okay? They control the etching, so they make it as a gel to place it in a places, okay, and not moving to other places, okay? So they add silica particles to the acid etching to thicken it, to make it more viscous, okay, to make it a gel. So this viscosity, this increase in the viscosity will make it more retained to the tooth structure than the liquid one, okay? So if you only remove it with the power suction and khalas and it's enough, no, you didn't remove it all. You have to remove it all. So you have to rinse it with a triple syringe with the air and water for at least 30 seconds. Okay, doctor?
It's okay.
Okay.
We can.
Okay. So
I don't know if I can interrupt. I have a question here.
Okay. So when you are going to,
we ask the question now, or we keep the questions at the end?
You can ask me.
Okay. What is the protocol if you etched more than 15 seconds and the patient still have pain or mastication?
You have to redo your restoration. You have to refresh the area, refresh the cavity, okay? After you're refreshing the cavity, you will create another smear layer, okay? Because what's the smear layer? It's the debris. It's a mixture of everything that's in the patient mouth, that's in the procedure, okay? So you will create another smear plug, you will create another smear layer and refresh the area. And after that, you redo your restoration, or you redo your etching and bonding procedures the correct way. Okay.
Okay.
Okay. So, do we have we speak about the drying procedure? Okay. So, do we need the tooth to be very dry or what? We need to have some wetness, some fluids, some liquids within the dentine mainly, not the enamel. The enamel, you have to have the chalky white appearance, it's up to you. But for the dentine, we have to make it like a little bit wet. Not I call it a dry wet, not wet and not dry, not chalky white, not like a chalk, okay? To make it a dull, it will be a dull appearance. It will have some water, but not too much water, not glossy. Okay, why? Because we have something within the bonding system later on called water chaser. What's the water chaser? We all know that the bonding system consists of a lot of things. The primer and the bonding, and sometimes the etching. Okay, so the primer. What's the primer? The primer is a solvent. Okay, maybe it's acetone. Sometimes it's ethyl alcohol, and sometimes it's water, and the bifunctional monomer. Okay, we all know that the composite is hydrophobic. Okay, so the introducing of monomer with its bifunctional monomer, okay, creates a link between the two walls, the hydrophilic and the hydrophobic wall. So the solvent within the primer, which is let's say ethyl alcohol, will drag the bifunctional monomer of the bond of the prime, sorry, and drag it within the collagen network and the dentin. Okay, so it needs water in order to what? In order to pass through it. Okay, so after that, the bifunctional monomer, which has the hydrophilic and the hydrophobic part, will do its work and bind both the collagen, mainly collagen type 1, with the bonding, the unfilled resin from the bonding agent. Okay, so we need to have some water. I know it's a complicated thing to understand at this webinar. I have a different lecture, let's say a 2-hour lecture for the bonding and the adhesive protocols. Okay, so I try to say it in simple words. We need to have some water within the dentin in order for the bonding system to work. You don't have any water, you don't have the bonding on the dentin. Let's be concentrated on the dentin. The enamel, leave it. Enamel is very good for bonding, predictable, everything is okay. But the dentin is the most complicated one, because dentin at the same patient, you have the right sex and the left sex. Okay, you do your bonding, measure your bonding, you will find at the same procedure, you will find that your right one may be stronger than the left one, or vice versa, because you have no clue that you will have a certain amount of strength, like 20 megapascal or something else, strength from the dentin. You don't have any precise number. Okay. So after doing etching, here I said aging. What's the meaning of aging? Aging comes after the bonding, but I say I use this term here because the procedure to prevent the aging is after the etching, but also before the bonding. Okay, so what's the aging? There's something called matrix metalloproteinase enzyme. This enzyme is normally produced by the tooth from the dentin in order to, or as a response for the acidic attack from the caries, from the food, if there's an exposed dentin, or from the procedure that we're using, the acid etching. Okay, so the matrix metalloproteinase enzyme, it's an enzyme. It do lysis. It lyses what? It lyses the collagen. So if we have a bonding, the collagen will wrap around the bonding agent, okay, and form the hybrid layer, the hybrid zone. This is the bonding of the dentin, okay, dentin, not enamel. Okay, so if the dentin of the tooth produces the matrix metalloproteinase enzyme, it will cause this collagen to degrade, okay, so it will hydrolyze and it will be removed. So the bonding will be lost from the dentin area. So after that, the patient during mastication will have some pain during the mastication. So when it will happen, mainly 3, 4, 5 months after the procedure. So the first pain from the mastication is after 1 day, 2 days after the anesthesia is removed, okay, which is from the what? From the over etching of the dentin, okay. The after 4 or 5 months is due to what? Due to the matrix metalloproteinase enzyme, okay. So how to prevent or how to counteract the effect of matrix metalloproteinase enzyme? We have several methods. First of all, the chlorhexidine. You can use the chlorhexidine 2% in water, okay, and soak the cavity for 10 to 20 seconds after etching, before bonding, and don't rinse it with water and triple syringe. Dry it the same way as you dry the water, okay, and leave the cavity dull dry, okay, dull dry. يعني not very dry, not very wet, between, dull appearance, okay. بالعربي شاحب يعني. Okay. After that, you do your procedure like bonding and apply your bonding agent. Okay, don't rinse it with water. The second thing, you can use an acid etch that contains benzylquinone chloride. It's an antibacterial component that some companies added to the acid etching gel. It's very strong. The literature says it's like twice or triple the effect of the chlorhexidine and sodium hypochlorite for preventing the production of matrix metalloproteinase enzyme. But it's very expensive. The tube of the acid etching costs like $20. The normal one will cost like $7, something like this. In shekels, 3 tubes of Spident acid etching, 45 shekels. The acid etch HV from Pisco that contains the benzylquinone chloride cost like 100 shekels. Okay? Or you can use the desensitizing agent that contains glutaraldehyde after acid etching before the bonding. Okay? Those are the 3 ways that you can counteract the effect of matrix metalloproteinase enzyme. Okay, very important. Dr. Al-Muhib, any questions till now? Everything is clear?
No, everything is clear. If you have questions, I will tell you.
Okay. After we finish the acid etching, okay, we have to do the bonding. The bonding, it's like a new world, okay? There's different classifications, multiple classifications. I choose like 3 sections of it because I don't have the time to speak all about bonding. There's a classification from the first, second, third, fourth, till the 7th generation and the universal. And there is a classification depending on the use of acid etching as a separate or using the acid etching with the bond, okay? So let's say that there's a gold standard in 2 ways. The gold standard with the traditional way, the etching, rinsing, then priming, then bonding is the 4th generation bond. It's the most predictable and the highest success rate, okay? But it takes time and it's a technique sensitive. You have to pay attention for every step that you are doing. For the etching within the bonding system, the 6th generation is the gold standard, not the 7th generation, as they said always, or the universal bonding. Okay, so the 6th generation that have the etch and the prime in the separate bottle, then the bonding in the other bottle. Okay, last of it is the universal adhesive, and there is always a misleading from the companies that say this is a universal bonding. This is a universal bonding. No, not all universal bonding is universal. Not all 7th generation bonding is a universal bonding, because if you want a universal adhesive or bonding, you have to have what? MDB, 10 MDB. It's a component, it's a functional monomer within the bonding system, okay, that have the effect of chemical bonding of the composite restoration. We have always said that micromechanical bonding, micromechanical reaction that cause the composite to bind to the tooth. Now we can say that there is a chemical bonding with the introduction of the MDB. Okay, MDB. This is the universal adhesive. Okay, let's say the 4th generation, the etch is separated from the prime, from the adhesive. It's a gold standard, and there's a literature that said there's a 13 years retention rate of 94%. 94%. It's like a huge number for the composite. Yani 13 years success rate. This is amazing. Okay. This is an example, the Optibond FL from a Kering company. Okay. Another one, the 6th generation, as we said before, the etch and the prime at the bottle and the adhesive at the other bottle. Okay, they have a 96% retention after 13 years. Okay, this is from a company called Curary. Okay, this is the ultimate bond in my opinion. Okay. And there is the universal. Those are examples of the universal bonding. There's from Pisco, all bond universal, Scotch bond universal from 3M, OptiBond universal from Kerr, and chlorophyll universal bond from Curry. Okay. At the first 3 years, we have a success rate reaches to 98% if you do the etching and separate etching and bonding with this type of bonding agent. Okay, but after 36 months, which is the 3 years, there's a drop. There is an annual failure rate that reaches 3 to 4% per year. Okay, so at the first 3 years, you will have a very good an ultimate success rate for the universal bonding, but after that it will drop dramatically. Okay, so the gold standard, as we said before, is the 6th generation and the 4th generation for the separate classification. Okay, clear? I don't have the time to speak all about bonding. I told you before, I have a separate lecture, like 150 slides. I don't have the time to speak about it. Okay, this is an abbreviation of it. دكتور كله تمام؟
Great, thank you.
After that, let's say something about the polymerization. We use our composite and bonding system, but we have to know some of action, the reaction. What's the type of reaction? There's a photopolymerization and chemically polymerization. What's the meaning of photopolymerization? It's the use of light cure to polymerize or the composite. And the chemical, it will do polymerize or do react within without the use of the light cure. For the photopolymerization, we have to know that we have different type of material. We have different type of initiator, such as camphorquinone, the most common, okay, and phenyl propanedione. Okay, so there's a difference between them. Camphorquinone works at the blue light, the normal Chinese light cure, like this, okay? It's a blue light, only blue light. But other type of photoinitiator works at the violet light, okay? So you have to read, I have a composite, take me a second. I don't know if you see it. This is called beryl from Kilzar, okay? It has, do you see it?
Yeah.
Okay. This type of composite have two photoinitiator, okay? The camphorquinone and the propanedione that works with the violet light, okay? So it has a different type of light cure that have the two waves, the blue one and the violet one, okay? So you have to read all about your composite. If you do cure it only with the normal light cure, it will cure, but it will not fully cure. And later on, it will fade, okay? So you have to read all about the instructions of your composite and the component, mainly the initiator, okay? Secondly, the chemical polymerization. This is a very important area to speak about. The chemical polymerization, the chemically polymerized bonding agent is very important to use when you are dealing with a deep cavity, when you are dealing with a post and core, because we all know that that the light of our light cure lost its strength, okay, with the distance. Every 1 centimeter will cost you 50% of the strength of the light cure. So let's say that we have a post and core that we are going to build with the fiber post, and we have a ferrule effect from the cement to enamel junction. If you see me, I will draw an animation for it or a picture for it. This is the root, okay? and this is the gingiva, and this is the feral effect. Okay, let's say دكتور محب شايفين؟ دكتور؟
It's better now. It's better now. Continue.
شايفين الرسمة؟
إذا فيك تقربها أكثر شوي للكاميرا. ممكن تقربها أكثر للكاميرا الرسمة تبعك.
Okay. Let's say this is a tooth that you are going to build it with a post and core, okay? With a post, fiber post, and you can build it. Okay, so the recommendation is below the cement to enamel junction, at least 5 millimeter preparation for the root canal, okay? This will be enough for retaining the fiber post and will have all the physical properties that you need. Okay, so there is a 5 millimeter here, and for the feral effect, at least you have to have 2 millimeter. Okay, less than that is not enough. You need to crown lengthening, blah blah blah. So you have to have 2 millimeter. So combine it to each other, it's 7 millimeter. So you already lost like 50% of your liticure strength. Okay. So after you lose your 50% of liticure, you have to add to that the fact that you have the opacity of the material for cementation and the opacity of the fiber post itself. So you will have no light emitting within the last point of your canal, of your preparation. Okay? So you will have what? You will have unpolymerized cement bond, and you will have a failure of your build up. Okay, after like 2 months, if the patient ate something sticky, you will have the crown. So let's say the crown with the fiber post, with the cement around the fiber post, not on the tooth. Okay, you will have it failed, and I do have some cases like this. Okay, not for me. So what should we have? We have to use the bonding agent with the chemical activator, okay, such as benzyl peroxide or tertiary amine, okay, as a co-initiator. Okay, those are the examples that for the bonds that we use. From Tokoyama, Palafic Universal Bond, I have it here. Let's see. This is the one that I use. Okay, and from Dent Supply Sirona, you can use the Universal Bond from Dent Supply Sirona with the activator separately. You can buy it separately, but it's very expensive. Okay. We finished the acid etching, the bonding, polymerization. Okay, let's talk about the filling. Okay, what's the main problem of the composite restoration? The shrinkage that will cause the stress. The shrinkage always toward the center. The composite shrink toward the center. So what are the strategies that we can use to prevent the shrinkage or to compensate the effect of the shrinkage on the tooth structure? We can have our strategies like C-factor, incremental layering technique, light curing techniques, and stress absorbing layer, the flowable composite, bulk fill flowable composite, and incorporating a micro filler or pre-cured filler. Okay, let's talk about the C-factor. C-factor in simple word, the unbonded over the bonded. Okay, it's the ratio of the bonded surface of the restoration to the unbonded surface of the restoration. Okay, this is an example. This is C-factor equal unbonded, it's 1, the one surface here, because it's not binding to other surfaces. Where is the mouse? Okay, here. Okay, this is one surface over one surface. So the C-factor is 1. In this case, there is two surfaces that's bonded to one surface that is unbonded. So 2 divided by 1 is 2. Okay, at this picture, which is a class 1, there is 1, 2, 3, sometimes 4, 5, the mesial and the distal, okay, over 1. So the result of C factor is a 3. So what does that mean? Any number above 2 is very dangerous for the tooth and can cause a fracture, okay? Okay, not any fracture اللي هو let's say it has an upfarction. They say upfarction fracture, something maybe. Dr. Muhammad?
Yeah, I'm hearing you.
You can't hear me?
I'm hearing you. I'm hearing you.
مش فاهم.
عم بسمعك.
Okay. So the C factor, any value above 2, you have to consider it as a danger zone. So how to manage it? Okay, by doing a layering technique. What do we mean by layering technique? To engage at most 2 surfaces at once, okay? 2 surfaces at one time, okay? With the thickness of this surface, with this layer, is less than 2 millimeter for the light to pass through it, okay? This is an example. This is a case. I did use the shield, okay, and pre-widget to protect the adjacent tooth. Then I use the matrix system. This is 6-channel matrix system. You can use any type of system if you pre-curve it or adapt it well, okay? After that, I simplify the case. I turn the case from class 2 to class 1. So I build the missing mesial wall, okay? Then initiate my incremental layering. I don't have the photo, so we don't want to use the horizontal one because it engages more layers. Let's say there's 1, 2, 3 over 1, so it's 3. We don't want it. We use the horizontal or the oblique layers, so it engages at the same time 2 surfaces, bonded surface over 1, so the ratio will be 2 or less. Okay. After that, I did finish my composite. Okay. But we have to stop here. Let's say we have to stop at the cement to enamel junction. Anybody knows why? You can build the layers. Okay, let's go back. You can build the layers here, 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 but you have to stop at the cement to enamel junction, or you have to stop when you engages enamel. Why? And you have to treat the composite different way. Why? Any answers?
No, not answer now, but إذا فينا نستعجل شوي لأنه we're running out of time.
اوكي نسيت انا عن فطور. Okay. Why we have to stop at the cement to enamel junction? Because as we said before, it's 2 different type of materials. The enamel is a rigid, tough one, and the dentin is the more flexible, more organic one. Okay, so that can be reflected at the module of elasticity. The module of elasticity on the enamel is 85 gigapascal, which is a very tough material. Okay. For the dentin is like 18 gigapascal, okay? It's 18 gigapascal. So it's more flexible. For the composite that we use, it's ranging from 12 to 16 gigapascal. So the composite here is more similar or more flexible, such as that of the dentin. So the dentin itself will compensate the shrinkage that will happen to the composite because it's elastic at the same range of that of the composite. But for the enamel, if we cure the composite completely, okay, it will shrink, okay, but the enamel will not compensate the shrinkage of the composite. So it will cause a cohesive fracture, which all we know, it's the white line around our composite after we finish the composite. Immediately after we finish the composite, you can see your border. It's a white line. And after 1, 2, 3 months, or after the patient eat chicken masala or something with stains, it will have a stain and micro leakage. Okay, what is the cohesive fracture? Because the enamel couldn't compensate the shrinkage that happens to the composite, the composite will separate some of the enamel and cause a fracture of the enamel around the restoration and make a gap, a micro leakage gap between the composite and the enamel. Okay, this is called the cohesive fracture. So how to manage that? We are going to talk about the light curing. The light curing, the idea is to use a pulse delayed light curing. What's the pulse delayed? The material, it's like a living creature, okay? You have to treat it well to have the best results from it. So how can we treat it? You do like a single light, a single pulse of light for like 1 second. This will initiate the reaction, but the reaction takes its time if you stop. Okay, it will form a longer chain. It will have more particles that bind together, so less free radicals, less free particles, less free arms, so less free radical formation. Okay, and after that, after you let it rest for 2-3 seconds, you light cure it for 5 seconds. This will stabilize the material, make it hard a little bit. Okay, so you can continue your layering. Okay, and after you finish your layering, you complete your light curing by 1 to 3 minutes with cooling with the triple syringe. Okay, after you finish everything, after you check your occlusion, then you do your final curing for 1 up to 6 minutes sometimes. I have a brand called HRI from Anna Micron. The recommendation is like 5-6 minutes. I can post the sheet for you and you can read it. Okay, so the traditional way that we use, we all the time do curing for 20 seconds. This is wrong because you shock the material. The material will shrink more, will form a shorter chain. The depolymerization is the chain formation, okay? Is the formation of a chain is the transformation from monomer to polymer, okay? This is the idea for the hardening of the composite. So you need the longer chain, the more stable chain. The longer the chain, the more stable the chain, the less shrinkage, the less stress. So you have to deal with it with the light cure, pulse delay technique, not immediate shock for the composite material, okay? This is what we have been talking about. I do for like 1 second, then I wait for 2 seconds, 3 seconds, and then light cure for 3 to 5 seconds. For the enamel, I do cure not like this. Maybe sometimes I use this, but I like I remove the tip like 1-2 centimeters away from the enamel and do 3 seconds. 3 centimeters. That if I have like 1,200 milliwatt per square centimeter power for the light cure. If I go back 1 centimeter, this is 50%, so it's 600. Another centimeter, it's another 50%, so it will be 300. 300 can cure composite, but not completely cure the composite. So you have a hard surface that you can check your occlusion for it, and you can do anything you want to it. But it's not hard. It's not hard. If you have your prop and bunch it hardly, it will cause some marks. Okay. So after you finish your composite, the occlusal height, everything, you have to cure it completely for the seconds that we said, the minutes we said. Okay, and then do your finishing and polishing. The finishing and polishing is after the final curing. Okay, finishing and polishing after the final curing. Okay, so why do we leave it? It's like the dough. if you ever go to the kitchen and need some doughs, like have some wheat flour and some water, it can't be done just you mix the wheat with the water. You have to knead for like 10 minutes and leave it to rest for at least 30 minutes. The same thing happen to anything you do. For the composite, you have to leave it to rest at least for like 5 minutes, 6 minutes. The time you finished your occlusal check and you finished your like some trimming for the excess material, it will pass for like 1, 2, 3 minutes, and then you complete your light curing. This will let the material rest and retract toward the enamel, okay, not causing a cohesive fracture and full shrinkage, okay. Now I did finish my thesis part, let's say thesis part. Now we are going to talk more about the morphology and how to create the Facebook, Instagram, Snapchat worthy pictures, okay? Simple words. This is from Style Italiano, directly from Style Italiano. If you do those lines, this is for the upper and this is for the lower, simple lines, and you can have a very good restoration, okay? Let's say a Facebook restoration, okay? Let's say see some picture. This case, this is all the cases in this presentation is for doctors, okay? This case, this is the 5, 6, and 7. This is after the removal, and I did my caries indicator. And this is the total edge and the selective edge, okay? And this is the final results, okay? This is the final result. Look at the depth of the cusp, the coloration. I will show it to you next in the bracket part, let's say. Another case, this case, okay. I did remove it. There's a caries here. I use the caries indicator. It opens. Look, it's class 2. Okay, first of all, it's not class 2, let's say, and after that, it's a class 2. Okay, and this is the selective edge, and this is the final results. Simple lines, and you can create a work that's a masterpiece. Thank you for your listening, and any questions?
Thank you, Doctor, for this nice presentation. I love the cases. We have 2 questions here. The first one from Dr. Mahdi Zakhon. Do you build
one of my patients?
Yeah, do you build your proximal wall with strong flowable composite or with conventional composite?
Okay, I use both of them. I use the flowable composite. I will show it to you in the practical part, okay? I use the flowable composite, but not cure it, and then add the traditional composite, then trying to like condensating it to the matrix system, to the wall, to the matrix system, and after that do some shaping and then cure it. This will help us with the micro gaps that normally creates by using the highly viscosity normal composite, okay? The normal composite is highly viscous, okay? So it's not moving everywhere. So I use the low viscosity, the flowable composite at the margins, and add the composite and condensate it and cure it both together, not everything separately, both together, okay?
Another question, at the time of final curing, is it possible to cure all layers sufficiently?
Yes, if you imagine it, I do this 2 buccal cusp. I have a layer there, okay? Then I add a layer at the middle cusp. Then I add a layer, blah, 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 blah. So all these layers, sometimes it's at the same level. So because I built each cusp alone, okay? So they are at the same level. By the time I cure the first one, it takes the first second and then 5 seconds. So it's 6 seconds, okay? Then I did build the second cusp. So the light cure also will affect the first layer that we have. So it will take another 6 seconds from the second layer, and the blah 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 blah, etc., and you will have a full curing depth layer. And after that, you do your 1 minute, 2 minutes light cure. Clear?
Thank you, Doctor. I think we are running out of time, so we have to schedule another lecture for another day for the workshop for the demonstration. I think.
بصير. Okay.
ما عندنا كثير وقت نعمل demonstration اليوم. We don't have this time today.
Okay.
There is no more question. Yeah, there's another last question. And if other questions, can you please go to the page and you answer them?
Okay, I will answer all the comments.
Yeah, is C factor not decreased if class 2 cavity is transformed to class 1?
Okay, I said before, I do layering technique to decrease the C factor. Okay, so it transforms to class 1. Yeah, but I do layering to decrease the. We don't have the choice to choose to make the layering then the class 2. No, all the time you have to simplify the case. You have to draw your borders, then do your composite. Okay, so the layering technique combined with the light curing technique will reduce the effect of C factors. Okay, so all of that strategies used together will decrease the effect of C factor and the shrinkage. Okay.
Thank you, Doctor. Thank you for your nice lecture. We will soon fix another date to make the live demo, please.
Inshallah.
People are waiting for it. Okay.
Inshallah. I will be ready, inshallah.
Thank you. Have a good day.
Welcome. أهلا وسهلا. هلا فيك. هلا.